Hi, Dr. Gullberg here, continuing our infectious disease series. Today we're going to talk about the rifampicin group of antibiotics. Rifampin works by inhibiting DNA RNA synthesis and blocking the RNA polymerase enzyme. This drug has been used for decades. It's been a mainstay drug for tuberculosis. It's got excellent intracellular killing. It's a great drug for synergy against staph infections, both MISA and MRSA, as well as Pseudomonas. If there's a prosthesis present, we also like to add rifampin because of its ability to penetrate biofilms well, especially if staph epi is present. But don't ever use rifampin alone. We like to use it with other antibiotics as resistance can develop. And of course, warn your patients that their urine is going to turn bright orange, and they have to be careful they have contacts as well. There are some semi-synthetic rifampicins, including rifabutin, which is dosed in adults 150 to 300 milligrams a day. It's used for resistant mycobacterial disease. It has less drug interactions. There's a newer rifampicin called rifampin that's being used now in latent TB on a weekly dosing schedule. And there's rifaximin, otherwise known as Xifaxan, very poorly absorbed and used in IBS, as well as bacterial overgrowth syndromes and traveler's diarrhea. So just a good summary for rifampin and how we use it. You certainly you're going to need to monitor liver function tests on a regular basis as well when people are on rifampin, because it is metabolized through the liver. But in my experience, it's a very well tolerated drug. Lastly, we'll use rifampin if people cannot tolerate INH for some reason. For example, in patients with latent TB, where we like to put them on INH for 9 months with vitamin B6. If they cannot tolerate that regimen, we'll use rifampin at 600 milligrams a day for 4 months. So again, just a couple of quick pearls for you on rifampin and its analogs. Dr. Gullberg signing off.